Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Chris Darland. He is the president and CEO of PeerBridge Health. Today's Kevin MD article is Why Remote Patient Monitoring Needs a Preventive Shift. Chris, welcome to the show.
Thank you for having me. It's great to be here.
All right, so tell us what led you to write this article and then about the article itself for those who didn't get a chance to read it.
Sure. So all my family's from rural Kentucky, some outside of Louisville, some outside of Lexington. And my experience with healthcare growing up was largely in the ED. And it was my grandfather in and out of the ED, which at least felt like as I grew up, every 18 months, almost like clockwork for all cardiac issues. And what was interesting to me as I reflect on it is every time my grandpa would leave alive, it to him it felt like a miracle because the cardiologists were performing miracles, whether it was a pacemaker or he's going in for an MI, whatever. He always came home alive, which was fantastic. But I think there was an underappreciation for the anxiety that puts on the whole family. So it's my mom leaving school and sitting with him at the hospital. It's I can picture, dinner tables full of bills and pills, and did you take it or did you not take it? And although of course I'm super thankful for all the cardiologists saved his life, like in my head there was like there's got to be a better way. There has to be a way to prevent this, so it's not an ED visit that keeps him going, but a way that you catch it early, and that's pretty deeply embedded in me and my family. My dad still lives in the middle of Kentucky by himself at the end of a long gravel driveway, and there's tens of millions of people just like my dad. And I don't think we're any better now than we were 30 years ago when I kind of experienced this with my grandpa. So it feels like the time for the shift is now, and I'm pretty optimistic actually today.
All right. So you said that we aren't better off now than we were 30 years ago, despite the advent of all this technology, right? And we're going to talk about some technological options. So why do you say that, even though we have 30 years of technology that's in front of us?
Good question. So I think outcomes you might argue are a little better. I think a lot of the investment is going into like how do you save lives when people are already sick and they're sick. So heart pumps are fantastic. Pacemakers have made giant leaps and bounds. So for sure, I would say people are living longer than they were. But when I say we're not better, we're still not catching it earlier. We're just better at treating it after it's too late. And truthfully, I think it's really just in the last 3 or 4 years. I think there's this combination of better hardware that can get you out of the hospital. Because the reality is you could do preventative screening for everybody in the country if you got everybody in the country into a hospital and did echoes and did cardiac MRIs. Like we could find, there's not a lot of mystery left in cardiac. You could find almost everything, but of course that's not economically feasible. It's not logistically feasible. There's not enough echo techs in the country to even come close to that. So you need hardware that can get out of the hospital. So I think a lot of leaps and bounds improvements in technology. And then with a touch of this AI wave, which has brought costs down significantly so that you can start to layer on interesting signal processing tools. And now you can analyze this data without, rooms full of servers and somewhat it's like this LLM push of the chat GPTs and Claudes has brought costs down for the way we use AI, which isn't necessarily new, but it's been around for 25 years. But now you can do it in a cost-effective way, which then opens it up to everybody in a meaningful way. So it feels like not due to lack of effort or not due to lack of caring, but we're at this very interesting inflection point where lots of technologies are coming together at one time, which will fundamentally shift how we can treat preventative care.
So one of the things that you wrote in your article is that we want to transform that paradigm from a more reactive stance, of course, to a more preventive stance, right? So just tell us some examples of what that may look like.
Yeah, so what it looks like, we were out at a health system in San Diego last week, and they have a couple problems that they were asking for our help with. One was, we end up as a cardiology department seeing a lot of patients that don't really need us. After all, they were just alarmed by maybe a wearable or something that brought them in there, which of course isn't a great use of their time. And as we walked down the hall and they said, hey, our other problem is we've got a gigantic line of people in the ED waiting to get admitted or not. And we don't have a super thoughtful way to say, like, if you have chest pain, Kevin, did you pull your chest when you're working out or your back or is this an issue and we need to get you a bed? So I think what they're looking for broadly is not only, kind of rapid, really quick assessments of in this case, your cardiac stability or any cardiac issues, But I think just as importantly, a layer of intelligence on top that says, so what? Because I think there's lots of tools coming, and for sure, we do not have a data shortage problem in healthcare. In
Yeah,
fact, I think we probably have more data than we know
sure.
what to do with. So it's to be able to take all this data, let's say if our device can get to, let's say, 100 indications, that's fine, but that's not actionable. Like absorbing that into like, what I want you to tell us, Chris, is do they need a bed or not? And why did you come to that conclusion? And if you can give that to me in a paragraph, that's everything. Don't show me your layers and layers of technology and how smart your technical team is. Like answer that question. And then for the cardiology department, it was, I want to see patients that have this, this, and this, and those are the patients I can help. And if they don't have these 7 things, then the primary care doctor is completely fine. And here's the instructions we should give them. So it's all about, I've got limited time.
Yeah.
Take this powerful tool that you're working on, and lots of other companies working on great tools as well. But the output has to be as simple as humanly possible. Don't tell me anything more than I need to know so that I can make my next decision, which is either, admit or titrate drugs or move to procedure. But a lot of the doctors I talk to, I mean, it's still 7 minutes per patient. And no matter how advanced this is, if you're going to make me, spend another 20 minutes, I just
Yeah.
can't use it. And it's not a pragmatic tool for me. So I think really rapid, succinct, kind of, looking at 20, 30 years of medical history to say, Dr. X, the next step is this.
Sure.
That's what they need. And that's at least what we're working towards.
And that's what the beauty of AI and large language models are, right? It can distill just huge amounts of data and just give an answer to a simple question, right? And that really is the appeal of these large language models.
Yeah, that's exactly right. I mean, the way we view it is if we gave, let's just say we gave all the raw data to a cardiologist, for sure he or she would come to the right conclusion if they had a week to look through all these
Yeah.
research reports and really study, Kevin, you as an example, but they don't. So it's like, all right, well then we can take ACC guidelines and HRS guidelines and American Heart Association, and we can do that same week's worth of work in 10 seconds, and importantly be able to explain, like, here's why we came to the conclusion, here's what we're referencing. But that shortcut, which then they can reconcile to
Yeah.
15 years of education, I think is a big leg up versus even 2 to 3 years ago.
So let's take that example you were saying about the evaluation in the emergency department and
Yeah.
sending data to the cardiologist to determine whether that patient needs to be admitted or not. What kind of information can be transmitted remotely?
That's a great question. So we have one device right now that the FDA is reviewing, which has a cellular chip in it. So effectively, what we'll have is we collect ECG data, we collect an accelerometer, some impedance data, which then gets transmitted. Everything sits in our case, Google Cloud, where the compute happens. So part of what we're doing is if you take the data off the device, which can go off of cellular, it can go through a hospital's internet network, but that can usually be a little bit tricky for the IT team. So let's say we pull it off of cellular, we do the compute, we understand everything we can about the context of the patient. Then it all gets transmitted essentially as drops into the EMR. So what's interesting is that like I mentioned earlier, context matters. So what might get dropped to the ED doctor, you have the same underlying data. What might get dropped to the ED doctor is going to look wildly different than what the cardiologist needs to see. Like the clinical question the ED doctor is trying to answer is, do they need a bed?
Yeah.
Or not? And then the cardiologist wants to see, hey, the report said they need to be in a bed, but I want to understand why they needed to be in a bed. Was there a structural abnormality found? Do I need to do a follow-up echo? Is there some kind of hemodynamic stability issue? In which case, hey, we may need to roll them down the hall because they could be decompensating. But every person in the hospital who's going to interact with this patient is answering a different question, and it needs to all be caught and transmitted in that way. And the ED is a good example, but it doesn't need to be in the ED. It could be in the ambulance on the way to the hospital. Or more importantly, what I hope with this preventative shift is it's actually at my dad's house. So he puts it on at his house and he's wearing it for 5 to 10 minutes. He takes it off. Either his primary care doctor at the University of Kentucky, there's a cardiologist who looks at it really quickly and says, hey, Cleon, all looks good. Need you to wear it again next year. Or, hey, we've identified stenosis. If you come to the University of Kentucky, we can do a TAVR procedure, we'll give you a new valve. It's as minimally invasive as it can be, and then you're home the next day. And my bet would be, which we'll see because he's a pretty stubborn guy, my bet would be if I told my dad that, he would actually go to Lexington. He'd take the 2-hour drive. If I told him, hey, you're high risk, you should go see a doctor at the
Yeah.
University of Kentucky, the chances of him going are pretty much zero. So ideally, this is all remote, and it happens before you're even showing up in the ED, even if that's maybe the use case that this San Diego clinic was interested in. But for us to be effective, it has to be remote.
So from the patient standpoint, what exactly would that look like? What would the device look like? What's the patient experience like?
Good question. So I have one here. So the device is just a wearable that you put right on the center of your chest.
Yeah.
And for different things, you'll need different amounts of time. So we can get to one of the other things we're working on with the FDA is to be able to do a home sleep test. So let's say if you wanted to do that, you'd wear it overnight, 1 or 2 nights to get data. But if you just wanted this quick cardiac assessment, our goal is to do that in 5 minutes. So you pull it out, there's an adhesive you take off, you put it onto your chest. The new device that the FDA is reviewing, it has a mobile app on your phone that you'll say, hey, let's start the study.
Mm-hmm.
Take the device off after 5 or 10 minutes, or let's say the next day if you want to do a home sleep test. And in most cases, it's going to get mailed back to us, where we'll clean it off and make sure it's disinfected for the next patient. Some customers actually say, no, I'd rather keep it at the primary care office or at the actual hospital. And importantly, we're not sending anything to the patient.
Yeah.
So it's still a prescription device. My fear is always that it can be quite overwhelming what the patient may see, and then they kind of go into a panic or a tailspin over something that might be benign, and you really want the clinician to come with a plan to say, here's what we saw and here's what we can do. So all of our reports, although it may look different for a primary care doctor versus a cardiologist, it all starts with the clinician to kind of synthesize that data. We have somebody really smart on our team who leads commercial growth, a girl named Leah. She made the point, which I think is exactly right, is good monitoring finds everything, but that doesn't mean everything matters. And there's all kinds of things, false alarms and scares in the industry today that we really want to make sure the doctor's eyes are on. They're the expert. They know the patient context. They know if they just got laid off, it might be high stress, or they know if there's something going on in their life that might be causing maybe an irregularity for now. And all that is important to get to the clinical decision. And we feel pretty strongly that the clinicians stay at the center of everything.
So do you have any outcomes data in terms of some of these remote interventions, in terms of how it can certainly benefit patients and clinicians as well?
Very soon, I promise. So we just opened a 15,000 patient trial where we're running these full panels
Yeah.
on patients anywhere. We're doing some patients for the 15-minute sitting. We're doing some for a full 24 hours, and some that actually go 7 days. So you can pick up arrhythmia data and a few other things. So we're enrolling patients right now and that as we speak, and hope to have some results a little bit later this year. But feel pretty encouraged based on we have about 150 who have enrolled to date, that we feel pretty good about the impact we're having.
So in your ideal world, assuming everything gets approved by the FDA and the
Yeah.
data looks good, what would your ideal world look like, an ideal scenario an ideal scenario that uses your technology? What would that look like?
If I could have it my way,
Yeah.
this would be sent out to every rural American proactively in the country. And I say that because that's my personal background. That's what I'm passionate about. But the
Sure.
reality is even in urban settings, it's hard to get cardiology appointments. And our goal is to get the cost down for this device to $25. Is like, put it on really quickly for $25. We can find everything we need essentially to say you need to go to the University of Kentucky or you don't, in the case of my dad. And it's all done proactively. And the reality is heart disease progresses a little bit every year until it becomes emergency. It's kind of very slow and then all at once. So this is something, and this is what the data will guide us a little bit, but this is something that, let's say the data tells us that it really picks up at 60 or 65. Every year you're wearing this. And the more people we can do it, the less expensive we can make it, which is super important to us to reach the scale. But this should be the super tool that buys the clinicians a whole lot more time and gets the people who need to see them in front of them. I'm optimistic the payers will be excited about it because we should hopefully be able to remove a significant amount of readmissions and ED visits because you're catching things early. So the patients should be really excited because the reality is if you catch disease early, you can treat it with generic pharmaceuticals. You're not going in for surgeries potentially. And for those that end up, if I went to Denny's right now with my dad, I'm sure he's at Denny's right now.
Yeah.
Of the 10 guys he's with, there's probably 4 or 5 people that could use help from a cardiologist. So now you've got the University of Kentucky would look at it and say, well, that's exactly like we can help those 5 guys. And we can proactively bring them in, which is then they're doing the procedures that they want to be doing. and making the impact they want to be doing. So I think us being proactive and getting this in people's hands should benefit everybody who touches the healthcare system. So that's what I'm fighting like heck to do, is not to be a hospital monitoring tool, but really getting in people's hands early.
We're talking to Chris Darland. He's the president and CEO of Peerbridge Health. Today's Kevin MD article is Why Remote Patient Monitoring Needs a Preventive Shift. Chris, let's end with take-home messages they want to leave with the Kevin MD audience.
Yeah, I think I've got 3 kids. I think they'll grow up in a wildly different healthcare space than I did, and for sure than my grandpa did. I think we're at a really interesting spot. The message I'd give the clinicians is be demanding. I think there's a lot of tools out there. I think a lot of them, even a mistake I probably made earlier, was trying to create point solutions to solve this little thing, as opposed to, being the amplifier, the tool that can amplify you. I think clinicians do have to remain at the center of all things that are care, but be demanding, but be open, and let's try some new things. And like I said, I'm wildly optimistic. This is a hugely complicated place to do business, but it really does feel like we're on the brink of something special.
Chris, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you.